My presentation is on HIV epidemic among MSM and transgender people in India. I'll be talking about the current situation and what are the current national responses and the gaps. This is the outline of my presentation. I will just provide a brief overview of the HIV epidemic in India, and then I will talk about the various subgroups of MSM and transgender people in India. Then about HIV and STI prevalence among MSM and transgender, and HIV-related risk behaviors among them, and about structural violence and stigma faced by MSM and transgender people, and national responses, and finally gaps and challenges. This presentation is partly based on a technical report which I prepared for WHO Southeast Asia office. So this is actually for 8 countries, but I'm presenting only on India, but I'm providing updated information, and I'm also maybe talk about a little bit about my studies also along with this presentation. Okay, with regard to the general overview of the HIV epidemic in India, as you all know, you might have heard that India was the leading the HIV, it was having the largest number of people in HIV about maybe 7 years back. Now it is in the 3rd position. Now it's the 3rd largest country with having the people living with HIV. Now the estimation is about 2.23 million people who are living with HIV at the end of 2008. So previously it was about 5 million, about 7 years ago. And HIV, the infection in India was first identified among female sex workers from Chennai in 1986. So that was one reason why there was a neglect on the focus on sex between men, because it was widely thought it was primarily the heterosexual epidemic which is driving the epidemic. Only after 10 years, the National AIDS Control Organization acknowledged there is epidemic among men who have sex with men. That was the official statement only after in 1997, nearly 10 years after the epidemic. So if you look at the HIV prevalence in the general population, it is relatively very low, 0.29%. But when you compare that with the risk groups, what the NACO calls as core high risk groups, NACO is the India's National AIDS Control Organization. So it's nearly 10 to 20 times higher than the general population rate. So this you can see the decrease in the adult HIV prevalence in India, from 0.45% to 0.29% recently. And this is the estimated number of people living with HIV. I told you it's 2.27 million. Actually, they revised the estimates. Previously it was here it was 5 million. Based on the National Family Health Survey, they actually revised retrospectively all these numbers. So that's why you can see it's 2.7 million here, because it was actually 5 million at the time. Okay, as I had told, the HIV prevalence among the core populations, you can see the mean HIV prevalence among MSM is 7.4%, and among injecting drug users 9.2%, and female sex workers 4.9%. So this could be because there have been a lot of interventions among female sex workers since the epidemic. That's why it is now actually the lowest among the what the NACO calls the high risk groups. But of course, ID is also it's quite high, because it was also not addressed properly by the Indian government until recently. Okay. So NACO has estimated the population size of men who have sex with men. So according to NACO's estimation, there's a total number of about 2.3 million men who have sex with men in India. According to NACO, they had some formula and they have come out with this. And now NACO also says there's approximately 0.23 million male sex workers in India. But however, we don't have any reliable estimates for hijras or male to female transgender people. But for program purposes, NACO wants to state like there's a population of about 0.3 million high-risk MSM which NACO wants to target for HIV prevention work. So the coverage of the HIV prevention program is actually based on this number. So this is actually taken as like the 100%. So what do they mean by high-risk MSM? According to NACO, it's like if it's more than 15 partners per month. So NACO is going to, it is saying like we will target only like those people like who are having more than 15 partners per month. It's like, of course, we can't able to find out like who is having that many number of partners. The assumption is like, because the NACO has primary site-based targeted interventions, people who are coming to the cruising sites, they are more likely to have large number of partners, and that's why like that's the assumption by the NACO. Okay, so and there are various studies which have shown that like the prevalence of same-sex behavior among Indian men is varies from anywhere from 6 to 13%. Some of these studies have been done among general populations, and some are from the STD clinic attendees. So this is just to like show how the size estimation compares with that of other risk groups. Like this is like 10 lakh is 1 million. So this is like 0.3 million MSM, like 1.2 million female sex workers, and I'd use like 0.1 million. Okay, so that's just to provide a brief overview about the HIV epidemic in India. Now I'll briefly talk about the various subgroups of MSM in India. Okay. So MSM, as you know, is like a behavioral category. So any men who have sex with other men, they are labeled as like men who have sex with men, regardless of their sexual identity or sexual orientation. So in India also, like the common term is like men who have sex with men, or sometimes they may use like males who have sex with males. But the major proportion of men who have sex with men in India are those people who do not have a self-conscious homosexual identity. So that's, I think, maybe true in other developing countries or even in developed countries. So even in my like clinical practice, like I have seen like men who may come and tell like they had sex with men, but they will say like, yes, I had sex with a homosexual. So they don't see themselves as a homosexual. So they will say, because there are some derogatory terms in Indian languages, so they will only use that term to refer, I had sex with, like for example in Tamil, there's a word called potai. It's a derogatory term. So they will use that term, yes, I had sex with a potai. So they will see themselves as only a man, because we don't have any terms for heterosexual in Indian languages. Nobody calls themselves as heterosexual, the heterosexuals, because there's no term, like there's no, so they think like I'm a man. Okay, man, I had sex with like a feminine person. Okay, so I think that will be the commonest category among men who have sex with men. But unfortunately, because all these site-based target interventions are like at the cruising sites, and majority of them are actually used by people who self-identify themselves as coatis or double-deckers. I'm going to talk about that. So this particular population is actually left out. Like nowadays, like NACO uses a term called hard-to-reach MSM to talk about these non-identified MSM, because it's difficult to reach out to them. And maybe I will just, for the discussion purposes, I will just simplify. We can see like based on the class differences, some differences in the identities. People who are from the lowest socioeconomic class and who are same-sex attracted, some proportion, they may identify themselves as coatis. So coatis are like people who are same-sex attracted males, but they are feminine and who are mainly receptive partners in sex with men. Okay, so the coati is like a pan-Indian term. It is like used all over India, as well as even actually in Pakistan and Bengal. But there are some regional variations, like for example in Manipur, they just use the English alphabet A. So A MSM, B MSM. So A is like a feminine, like B is like masculine person. and they have AB, person who like penetrates and receives. So Kotis, they call the masculine partners as Panthis. So Panthis, according to Kotis, are supposed to be like heterosexuals. So, but they are like masculine, they penetrate, but they are like heterosexual. Their main attraction is towards like women, but once in a while they have sex with them. So that's why they call like Panthi as a like a real man. So they want to have sex only with real men. So Koti and Panthi, and Panthi is a label given by Koti. Panthi is not an identity, but nowadays it's also like becoming identity. Some people, they start identifying themselves as Panthi. And actually, like I have seen in Mexico conference, there was one person in a session who identified himself as I am a non-identified MSN. So I thought it was a joke. It wasn't. He clearly told like he's non-identified MSN. So. And Kotis call those persons who like penetrates and receive as like double deckers. So again, like double decker used to be like a label given by the Kotis, but nowadays again it's becoming an identity. People started identifying themselves as double decker. So there are some regional variations in the terms, like somewhere it is called as double, and somewhere it's like dupli, doubletta, for example, in Calcutta. So there are some regional variations in these terms. However, even though we talk about like based on the gender expression, there's a varying degree of femininity among Kotis. So they need not be like obviously feminine, and also like Kotis can also like penetrate, but the assumption is like Koti is not supposed to like penetrate. Okay. And people who are from the middle and upper class, again, like majority of them, they may not have any conscious same-sex sexual identity, but some proportion they may identify themselves as gay, and some very rarely, like some very minor proportion also identify themselves as bisexual. Okay, and coming to like transgender people, there are several terms which are used. Like, I think the common terms which you might be aware is like hijras. Aravan is used in Tamil Nadu. Like these are like used in other parts of India, Jogti, Lama, or Sivsakti. And among the hijras, before the operation, the sex change operation or removal of the male external genitalia, they call themselves as aqua. So aqua is equivalent to pre-operative transsexual. And after the operation, they call themselves as nirvan. Nirvan hijra, aqua hijra. So nirvan is like a post-operative. And some people are like non-operative. No, the hijras, they may not also like undergo operation at any point in time. Like, okay. So that's briefly about the major subgroups. I just wanted to show some photos, not to like show that like they are like different. They are like if you see them on the road, you may not be able to identify. I just want to like just to show that like. SWAM is like a community-based agency where I have my research projects with in Chennai. So you can see like they primarily work with Koti identified MSN. Of course, when you look at this, you may not be able to tell who is like Koti or double or Panthi. So, okay, this is like from the drop-in center of SWAM. Again, okay. So Panthi, anybody who is masculine is Panthi. So there is like, according to Koti, is like anybody who is like a masculine is a potential sexual partners. So this person is like a hyper masculine. Like, so it can be like any masculine person is like a Panthi. Okay, so hijras, this is like from a particular book cover, like hijras Kuya. Of course, nowadays like. We are in India, like they are not using the terms eunuchs, like because it's not like a proper term to use. Again, this is a person like a hijra person from actually northeast. A person like a transgender person. Now, there's also like differences between like some people they are male to female transgender, but they don't identify themselves as hijra. For example, this is a particular transgender activist. She may not want to identify herself as a hijra, but she may identify as yes, I am a transgender woman. So, okay, so that's about the subgroups. Now coming to the HIV prevalence among MSM and TG. See, whatever data we have is primarily from, like one is from the government data, national HIV surveillance data. Other thing is actually from the AVAGAN, the Gates funded projects like integrated biological and behavioral assessment. And also there are a couple of other data from clinics who are clinics from the community-based organizations working with MSM. So apart from that, like we don't have actually very much like diverse data sources on HIV prevalence among MSM. So in 2008, the government serosurveillance sites were like about 56 sites for MSM, and there was only one site for transgender people. So actually, we don't know much about like the prevalence of like HIV among transgender people, but whatever data we have, the source is very high. I'm going to just talk about that also. So here you can see, I already told about the mean HIV prevalence of among MSM. It's about like 7.4%, but there are obviously like variations according to different states or different regions. So these are like, I'm just showing like 4 different states, 4 or 5. So the Andhra Pradesh, Tamil Nadu and Karnataka are southern states. Maharashtra is like west, Delhi is in north. You can see maybe except Maharashtra has a decreasing trend, and everything else actually there's an increasing trend. I'm not actually showing like the 2007 to 9 data, but like it's still provisional from NACO, so now NACO hasn't confirmed that. So that also, but it shows like an increasing trend in all these 3 states like Tamil Nadu, Andhra Pradesh, Karnataka. There's an increasing trend. But maybe you know about like the decreasing trend of HIV prevalence in southern states, like in India and among the general population. But in contrast to that, actually there's an increasing HIV prevalence among MSM from the same southern states where the interventions are working among the general population. Okay. So STI prevalence data, actually we have very little data, because government, they don't have a STI serosurveillance. They only have like HIV. But maybe only from the Tamil Nadu government, they have some STI surveillance data. And again, this is from the AVAGAN data, and one of that is actually from my study. Like so, it's like this one is the syphilis prevalence, like lab confirmed syphilis. Like it's about, it varies from 8 to like 14% syphilis. And other STIs actually, like we don't have much data. This data is only from the IBBA, like Integrated Biological and Behavioral Surveillance of AVAGAN program. So it's like chlamydia is like 1 to 4% and gonorrhea is less than 1%. So that's the only data we have, but we don't have much data about the viral STIs actually.
May I ask, with the syphilis, is that an RPR, or is this
it's a VDRL, yeah.
So this
VDRL.
is ever having had,
yeah, VDRL and TPHA, yeah.
So this isn't active syphilis, this is history.
Yeah.
Okay.
Okay. Yeah, you can look at like the STI prevalence among HUAs. It's like Mumbai, like 57%. They had like syphilis. And HIV prevalence, I think I did not mention that. HIV prevalence, it's about, it can be anywhere from like 20% and like to 40%. In Mumbai, it was like at one point in time, it was like HIV prevalence 40%. And now it's about 18 to 20% among HUAs. Okay. Coming to the HIV-related risk behaviors, we have data primarily on the sexual risk behaviors, but we also have little data about on drug use behaviors also. Okay. So MSM, just like anybody else, like they have all type of sexual partners, regular partners, casual, commercial, or paying partners. And MSM, even though we say like men who have sex with men, they also have sex with say women as well as some of them, they also have sex with transgender people. And just to give an idea about the number of male partners, because NACO talks about like more than 15 partners per month as high risk. So you can see like the BSS data just like 1 to 15 in Bangalore. I'm just giving an idea in Bangalore, and 2 to 30 for commercial partners. And the prevalence of yeah. Thank you. Okay, and this is the percentage of MSM who have like sex with women also. Like it varies from like nearly 12.6% to about 70%. So there are quite regional variations. And actually, if you look at like this low, if you see this as a low, actually like in the surveillance sites, like the age group, majority of the age group are like less than 30 years. But many of them, they get married like by 25 years, 30 years, and even after that. So we hope that most of them will eventually get married, and this prevalence, like this proportion, may be actually like even will be higher. Actually, like it need not be like 12%, because many of them, they get eventually married to women because of a variety of reasons. Okay, condom use is again about 1/3 to 2/3 of MSM. They reported not using condoms during last anal sex with a male partner. This is like a BSS data, behavioral surveillance survey of government in 2006. They haven't actually released the data from 2009 yet. Again, like I'm not sure whether I mentioned here, the condom use with steady partners is low compared to that of with casual partners, or even like paid partners. And okay, and also especially the condom use with female partners, again, like it's very low compared to the male partners. And especially with the wife, like it may be very, very low because of a variety of reasons, like they may be afraid of marital discord, or the wife might have already undergone tubectomy. She would question why the husband is using condoms now all of a sudden. Okay. And water-based lubricants are not like commonly used by majority of MSM because it's not widely available. Also, like it's the cost is high because it's primarily available as like tubes. Like it will cost about like 90 rupees or 100 rupees. It's like $2, but it's still costly for majority of them. Okay, just is like consistency of condom use among MSM with commercial male partners. You can so compared with 2001 data, you can see like there's a definite increase in consistency of condom use. Like so, it varies from like about 19% to about 53%. So.
Is the improvement from specific programs in some cities and areas?
Yes. See, all these cities, NACO have programs. So they take this 2001 as the baseline, and then they followed up after like. But it's like of course it is not like a cohort. It's like a sample of the MSM population from those cities. So in all these, actually, they have interventions going on. So even in areas where interventions going on, you can see it's the consistency of condom use is like less than 60%. So actually in the next picture, like these are like new. For example, in Uttar Pradesh, there have never been like an intervention. So you can see the condom use, like it's like less than 13%. So these like a newly added sites, but actually they were having like interventions here, like only the sites were new. Like in 2006, otherwise they were having interventions. But you can see like wherever there was no like interventions, there's a very low consistency in of condom use. Okay, but this one is actually among like non-commercial male partner. Actually, they did not provide details about like steady partners and casual partners. If you want to show a graph, it is like between steady partner versus other casual partners, with casual partners, then I think like it will be quite different. With steady partners, it will be very, very low. Okay, and also we have very limited information about sexual risk behaviors of HIV positive MSM and transgender people. I have done some studies. One is like mixed method studies, another is this is a qualitative study. So, but only these two actually studies are available specifically on HIV positive MSM and transgender. So whatever studies which are available that actually indicate like risk behaviors among HIV positive MSM, putting themselves at risk for other infection as well as like putting their partners at risk. So there's actually definite need for positive prevention programs in India, because NACO is also talking about positive prevention, but actually they haven't developed any strategy for like implementing the positive prevention programs among what they call the general PLHIV as well as PLHIV from people living with HIV from other populations. Okay, drug use. Again, this information is again from behavioral surveillance data, like 2006. Primarily in Delhi, actually, there's a high percentage of MSM who reported like injecting drugs, nearly 30%. Majority of these drugs like heroin or dextropropoxyphene, like they call it spasmoproxyvan, and also pharmaceutical drugs. So it's primarily a cocktail of pharmaceutical drugs. So those are the common injections which are used. I don't think like nobody has documented, like for example methamphetamine crystals. No, we haven't like documented any one of those in India. It's primarily like heroin and pharmaceutical injections. And in 2003 you can see like none in Chennai, Calcutta and Andhra Pradesh. Like and
no studies or no one reported?
Which one?
No studies were done in Chennai, or no one?
No, from this data. From this data, from the 2006 BSS data, like there's none. Like in the past 1 year, they did not. But it's actually also related to the sometimes the drug control measures. So, for example, in Chennai, which is close to Sri Lanka, where there is drug peddling, drug smuggling happening, there's a very strict enforcement of like they will screen everyone. And therefore, actually, most of them, they move into like non-injecting drug use, or they may use a cocktail of the local medications like sedatives, sleeping pills. So that's why like they may not actually, like it depends on the question they ask. If they have asked like did you use like heroin or something like that, so maybe they would have say no. But if they have asked something else, maybe they would have said yes. Okay. And again, you can see like if we include like non-injecting drug use also, again from Delhi it's the highest. So nearly 50% reported any intoxicating drug use. So this actually like includes maybe something like the ganja, marijuana. Okay, but you can see like it's also like reported in other cities like from Bangalore, as well as of course it's still like from lowest from Chennai. Okay, so that's about briefly about the HIV-related risk behaviors. Now coming just briefly about the structural violence and stigma, because it's primarily because this poses both direct risk as well as indirect risk for getting HIV and for transmitting HIV. So I think most of you might have heard about the Delhi High Court verdict that they have read down section 377, which criminalized certain non-vaginal sexual practices. Actually, because it was actually criminal to have anal sex or oral sex even between husband and wife. So that's why like section 377 was actually not about like criminalizing same-sex behavior. It was actually like criminalizing any non-vaginal sexual practices between two adults. Okay, so what the Delhi High Court did was, it said like we can read down section 377. So what they mean by read down is like it will be no longer applicable if the sex happens between two adults in a consensual manner in private. So that's what they mean. However, like there has been appeal against this judgment because it's a High Court. It's not like Supreme Court. So there's an appeal against this. And there's actually going to be a hearing in June or July in the Supreme Court. So still it's in the court. So you may think like India has actually like legalized. No, it's not. It's still like it's in the court actually. So And in relation to structure, it's again like negative attitude towards same-sex sexuality and stigma attached to being HIV positive, MSM or transgender. It has considerable implications on people like talking openly about like HIV risk, or if they are HIV positive, they may not want to come out openly as HIV positive. It's the like same thing for whether they are heterosexuals or whether they are like homosexual persons. Okay. And actually, the stigma attached to like, even if a person is a feminine person and positive, like then the person may be seen as, okay, this person is more likely to be like a homosexual, because you also see the gender expression as like a proxy for the homosexual orientation. So there's also a stigma attached to being feminine. So I will talk about that, what we can say as gender non-conformity stigma. Like, because that's one of my study actually like interested area. Okay, so you can look at this paper of mine, structural violence against co-identified MSM in India, in which we talked about, that was in 2007. So at that time, still Section 377 was intact. So because there was like police who were actually raping men who are sex with men, so it's like they could not able to report any sexual violence to the police. So it's like it's quite difficult. That's why like, but even now, because majority of these MSM who are standing in the cruising sites, they're also engaging in sex work. Even though Section 377, you can say like has been read down, majority of these MSM in sex work, the police may say you are in sex work. Sex work is still like illegal. Even though being a sex worker is not illegal, standing on a public place and soliciting is illegal in India. So still like there is ongoing like sexual violence from police and ruffians, which are faced by MSM who are visiting cruising sites. And there's a new form of like blackmail because of increase in internet use. People who are even previously actually like only majority of the co-identified MSM, they used to face violence. Nowadays, because of the increase in internet use, internet has also been used as to blackmail. People use that as a trap to bring the persons to some areas, and then they blackmail and then they extort money, even from people who may not have any identity or people who may identify as gay. Okay, and this is the study which I mentioned. Like, so this is like a pilot study which I have just completed. So it actually looked at the influence of the impact of sexual stigma, gender non-conformity stigma, and culture-related stigma on the mental health status, depression, and sexual risk behaviors. So this we have found that there's a definite impact. There's like nearly like 50 to 60% of the MSM in the sample, 200 sample, they had severe depression, moderate or severe depression scores. Okay, and coming to the national responses finally. Okay, so currently we are in the third phase of National AIDS Control Program, and the third phase is going to end in 2012, next year, and that's why now there's a fourth phase planning is happening now. And only in 2006 and 7, like there was a development of operational guidelines for targeted interventions among MSM. Before that, there was actually none. Only from the third phase of the national program, they explicitly mentioned MSM and transgender in the strategic plan of the government. Before that, it was not at all there. And National AIDS Control Organization provides funds to State AIDS Control Society, which are like state government, and YACS provides support to the non-governmental organizations and CBOs working with MSM or other populations. So this is the like fund flow. And recently, like NACO has also developed what they call Ngo Cbo Transition Guidelines, because we differentiate in India. We differentiate as even though CBOs are NGOs, CBOs are all only managed by the community people. For example, the CBOs in the CBO, all the board members will be who are, for example, MSM, or all the board members who are like sex workers. So that's why like NACO wants the TA, the targeted intervention, to be directly implemented through the CBOs, and so therefore there's actually like transition from NGO to the CBOs. Okay, so these are the main components of the MSM-TA, like behavioral change communication, condom promotion and distribution, STI treatment referral to HIV testing, and creation of enabling environment. This creation of enabling environment is actually like only limited to talking to the local police people about the targeted intervention. It is not actually like decreasing the stigma in the local communities. It's not like that. But again, one obvious gap is insufficient budget for water-based lubricants in the national program. Okay, so among the TAs, there are two kind of target intervention. One is called, one we can call as like exclusive target intervention. Another is the composite TAs. So exclusive TAs are only exclusively for men who have sex with men. So there are about 132 TAs working exclusively among MSM. And actually among these, like 35 were managed by CBOs in January 2010. So, and each TA is supposed to cover about 400 to 600 MSM. For example, in Chennai, there are actually 3 TAs. So it's like, now actually NACO wants to be more efficient, and it wants each TA to cover 800 MSM. So at parts of its efficiency drive. Okay. And I will talk about the coverage in the next slide maybe. So this is exclusive TA, and there's another thing called composite TA. There are about 220 composite TAs. So composite TA is like in areas where you may not have adequate number of MSM to have a single like exclusive TA. For example, if there are only 200 MSM in a particular area, but there are 200 female sex workers also, so then you combine like 200 plus 200 as a composite TA. So that's like composite TA. So these are two mechanisms by which MSM are reached throughout India. So it's only site-based, like they go to the cruising sites, and there are no other like interventions for among the general population or even in other male populations like migrants or prisoners. No, there's no like specific like component addressing same-sex behavior. Okay. You can see the scaling up of target intervention. So it dramatically increased only. But this is the government one. This one is actually from other funding agencies. For example, majority of them were actually from Avagan, the Gates Foundation project. So only from here actually the government funding started from 2006. Okay, this is about like the approximate number of agencies working with MSM. So about like 150 organizations are working with MSM, and about within this 150, about 1 or 3 organizations they also work with transgender people, and about like 1/3 of them are I think maybe half here CBOs, and here like nearly 46 out of the 1 or 3 are CBOs. Okay, so coming to the coverage of like how many MSM have been reached out through the HIV prevention programs. As you might remember, like I mentioned, 0.3 million is the estimated number of like MSM, high-risk MSM by NACO. So by January 2010, through the target intervention, approximately like 275,000 MSM were reached. So NACO says, so this means approximately like there's a 78% coverage. But if you remember the earlier estimation of NACO, that MSM estimation was 2.3 million. So this is like only high-risk MSM, and from that was taken as the denominator, and this is the number of MSM who have reached to the TIs, and therefore the coverage is like 78%. That's the NACO's argument. Okay.
I have a simple mathematical question.
Mm-hmm.
If there are 150 organizations and each serves 400 to 600 people, it means the maximum number of people they can serve is 90,000. How are we getting 275,000?
Which one? No. This I'm not talking about like organizations who are being funded. This in a particular mapping study, they found that this many number of organizations are working with MSM and transgender. Not all these organizations are funded.
No, I understand that, but if those organizations, go back one slide again. Or maybe another one.
Which one?
Yeah, that one.
Okay.
If the exclusive TIs covers maximum of 600 MSM and you've got 150 of them, that's only 90,000 people. So where are we getting 278,000 from that number?
Actually, this is the expected coverage. This is the expected coverage. But some of them, they may actually reach out to like less than 400.
Well, then it's even less than 90,000. So the coverage has got to be much less than 78%.
Yeah.
Well, something with your greater number, that might be numbers of contacts and not numbers of unique individuals. I'm not sure how it's counted.
Okay, actually I can talk about the controversy behind the coverage once I finish. Sure. Maybe it's, because I also pointed out in my technical report to WHO, which so because there are some complications in how they calculate the coverage, whether it is reach or whether it is coverage on what basis. Like maybe I will talk about that. Okay, so this I already mentioned, like 78% coverage, this many number of people covered, this is the estimated population in MSM. Okay, and coming to antiretroviral treatment access, from April 2004, NACO started providing free antiretroviral treatment. This is from this NACO's data. So NACO's is like about 658 transgender people are on ART by the end of like 2009, but there's no data for MSM. Actually, we don't know, like because they don't collect that as part of their information in antiretroviral treatment centers. But through the CBOs and the PLHV networks, we observed that there are several barriers faced by marginalized groups, including MSM, in accessing this free antiretroviral treatment. Even though it is, because the government argument was it is free, anybody can access, why they are not coming forward. But there are many HIV positive MSM, sex workers, injecting drug users who are not using the free antiretroviral treatment because of a variety of reasons. One common thing was about the stigma. The stigma both from in the broader society as also within the own community. For example, even if I am HIV positive MSM, I may not want to reveal my status even to my own peers. Especially even if I am like MSM in sex work, that's also going to affect my livelihood. So there are a variety of reasons why people, they may not want to disclose their HIV status, and because then going to antiretroviral treatment center is it's like an open declaration that I am like HIV positive. So this is this one is this is in press, like this one study with Dubrow, like on barriers to free ART access among MSM and other organizations in Chennai. So we have found like several reasons for why people are not using the available free ART services. Okay, so coming to the resources available for NACP 3 program, I just wanted to say like only one point. This is the direct contribution from the government, 25%. Everything else is coming from the external donors. This may be significant improvement from NACP 2, because in NACP 2 there was actually virtually no government contribution. Government told like nearly 40% is coming from World Bank. Anyway, we are going to pay back the money to World Bank, so that is our contribution. So there was actually virtually no contribution in NACP 2, but in NACP 3 at least like there's a like 25% contribution from the government. Okay, so NACO has like 4 objectives in NACP 3, so like prevention, treatment, capacity building, and strategic information. So you can see like what percentage of like money available, the budget available is allocated for these objectives. Nearly like 70% for prevention, but we actually don't have any information about how many of these are earmarked for the various risk groups. And also, and very importantly, we don't have any information about the details of the distribution of funds for MSM or other core high-risk groups. Okay, so just to summarize the various gaps and challenges, as I have mentioned, like the national program is only like targeting MSM who are coming to the cruising sites or the hotspots. And the majority, and the outreach workers are primarily like COTI identified. So even if I'm like say I'm a Panthi or a double decker, I may not be want to be seen talking to a COTI identified person who is obviously like feminine, because I will be labeled as homosexual by others. So there are several issues like why the employing a peer approach may not be working. So, and again, like the MSM from the middle and upper class are left out almost like completely. People who are like gay identified or bisexual identified, and people who may not be coming to the cruising sites and primarily using like other modes of communication like internet or mobiles, all these are like gaps we are missing out. And since and most of the the intervention components, there's not much talk about risk behaviors with female partners, because the assumption is we are talking about MSM, so the talk is primarily with like the risk behaviors with male partners. And very little attention to the sexual violence, like there are no sexual violence prevention programs or any programs to mitigate the consequences of sexual violence until now, even now there's actually none. And this is another major gap, is lack of any program component in addressing the mental health issues faced by MSM. So it's primarily only looking at the HIV component. You distribute condoms, you talk about HIV risk and STI risk. You don't see that as there's no holistic program in addressing like other health needs of MSM. So it's primarily at the individual level, only like looking at the behavioral models. Okay. Again, the lack of structural interventions to address societal stigma and discrimination against MSM. There's no such like national program which addresses the stigma faced by people living with HIV or other marginalized groups. And there are several gaps in strategic information. I already pointed out there's only one surveillance center for transgender people, so we don't have much information. And also we don't have any information about HIV incidence. So all we have seen like HIV prevalence data. It can very well be like there are many people who are like dying now, and then there's a decrease. So actually we don't know much about like the HIV incidence, whether it is decreasing or increasing, we don't know. Okay, but anyway, these are the recent developments. Just last year, there was a major like funding from Global Fund, and this will support about 200 CBOs in 17 states. And it's likely to reach more than 0.45 million MSM and transgender people. You can see this more than the estimate of the NACO. Okay, so this is and it's like about $25 million for 5 years. And NACO has just started the defining of the NACP4. So maybe hopefully in another 1 year, like they will incorporate and they will be able to address like all the gaps in NACP3. And also, now interventions are being planned to cover hard-to-reach MSM and women partners of MSM. I was part of some development of some technical briefs for NACO on why there's a need to focus on other subpopulations of MSM and women partners of MSM. So now NACO is thinking about like